Here in AACR 2019 in Atlanta, two important trials were presented. One, it is about chemotherapy plus immunotherapy, in particular platinum pemetrexed-platinum, and the other important trial is the MYSTIC trial comparing the combination of anti-CTLA-4 and anti-PD-L1 to chemotherapy and single-agent durvalumab. Keynote 189 was a phase 3 randomized trial for patients untreated non-small cell lung cancer without EGFR and ALK translocation. The trial randomized patients to receive either the combination of platinum, pemetrexed, and pembrolizumab or chemotherapy, and the patients who received chemotherapy were allowed to cross into the immunotherapy arm. The results were presented 1 year ago in AACR, and they suggested a huge benefit in terms of overall survival and progression-free survival. Here in Atlanta, I presented the results of the subpopulation in a post-hoc, not pre-planned analysis for liver metastasis and brain metastasis, and the entity of the magnitude of the effect is exactly the same of the overall population. So to have or not to have brain metastasis and liver metastasis is not a criteria to decide to treat or not to treat patients with this combination. MYSTIC is a phase 3 randomized clinical trial for advanced non-small cell lung cancer comparing chemotherapy to durvalumab alone and to the combination of durvalumab and tremelimumab. The results were negative for the primary endpoint of the trial, and there was a primary analysis, retrospective analysis, suggesting that a tumor mutational burden of more than 16 could be a good predictive biomarker to select patients for immunotherapy. Here in Atlanta, Solange Peters presented another analysis with a different cutoff of TMB of 20, which is able to select better those patients who are suitable, who most likely benefit of a combination therapy with durvalumab and tremelimumab. This is a subgroup analysis, this is research, but it is possible that tumor mutational burden on blood will come and will help for the selection of patients for this kind of treatments. My conclusions are that in 2019, the combination of chemotherapy plus immunotherapy is a standard of care for non-small cell lung cancer patients. For PD-L1, more than 50% we can decide to use either the monotherapy or the combination therapy. But maybe in the next future we will find a subgroup of patients that can be potentially characterized by high TMB, PD-L1 positive, that can benefit of single-agent immunotherapy or combination immunotherapy.